This is Ian Bodford.
And Liang Liu.
And welcome back to the Clinical Correlation.
Today's case is
Under Pressure.
This is a 45-year-old male with no past medical history who was brought in by his wife for confusion. He had fallen in the bathroom at some point and hit his forehead on the ground.
The wife had seen him earlier in the morning and found him around noon, unconscious on the floor of the bathroom for some unknown period of time.
Per his wife, he was getting progressively more and more confused since she found him after the fall.
But all that he complained of was left leg pain.
His vital signs are remarkably normal.
On exam, you note a contusion above his left eye. His left thigh is also noted to be around 2 centimeters larger than his right. He has decreased strength in his left lower extremity.
A syncope workup is started in the ED, including labs, EKG, and CT head. An X-ray of his left thigh is ordered, as well as a DVT ultrasound due to his leg swelling.
The EKG returns with flipped T waves in V2 and AVL. Interestingly, he also had peak T waves seen mostly in V3 and V4.
At this point, the patient was taken to the CT scanner. However, he became combatant and was brought back to the room. It was decided to electively intubate him due to his increasing altered mental status and need for further workup with which he was unable to cooperate.
CT head was performed and only revealed a soft tissue hematoma with no intracranial abnormalities.
His labs begin to return and there's not a normal value in sight.
Not so surprisingly with his EKG changes, his potassium comes back elevated at 6.3.
His CK is also extremely elevated at 171,000.
His urine has large blood with few RBCs, likely due to myoglobin.
And not surprisingly, with the CK level, he has an elevated creatinine.
X-rays of his left femur are performed and show no fractures, and his DVT ultrasound is negative for a clot.
On re-examination of the patient, you note that his left eye is now 4 centimeters larger than his right and becoming more tense.
He has lost a palpable dorsalis pedis pulse. However, it is still Dopplerable. You give your orthopedic doctor a call.
Compartment syndrome is increased pressure in one of the body's compartments, usually in the extremities, that leads to a decreased perfusion of that compartment's contents, including the muscles, nerves, and bones, as well as structures distal to the compartment.
The most common cause of compartment syndrome is traumatic injury, usually a fracture. However, there are other numerous causes. These include crush injury, immobilization, snake bites, burns, prolonged use of a tourniquet, fluid extravasation into a limb, including hemorrhage or iatrogenic causes, soft tissue infection, constrictive cast, and extreme exercise and exertion.
Generally, the compartment will be swollen, firm, and tender when squeezing it.
Symptoms typically occur close to the time of injury. However, it can be delayed up to 48 hours.
We are taught the 5 Ps of compartment syndrome in medical school.
These are pain out of proportion and with passive motion, paresthesia, pallor, paralysis, and pulselessness.
Although this is a nice memorization tool, a meta-analysis study published in the Journal of Orthopedic Trauma in 2002 reported that the sensitivity of the 5 Ps is as low as 13%, and the positive predictive value was just over 10%.
The specificity and negative predictive value were close to 100% though.
This likely means that the absence of the 5 Ps are more valuable than their presence, and maybe we should not be using them to help nail the diagnosis of compartment syndrome.
All extremities can be affected in compartment syndrome.
The most commonly involved is the anterior compartment of the lower leg due to a tibia fracture. Compartment syndrome can occur in up to 10% of these fractures.
Signs of compartment syndrome of the anterior compartment would be loss of sensation between the first and second toe and weakness of dorsiflexion.
The lower leg consists of 4 compartments, including the anterior, lateral, superficial posterior, and deep posterior compartments.
Although rare due to its size, compartment syndrome can occur in the thigh as in our patient. The upper leg consists of 3 compartments, including the anterior, medial, and posterior.
Like the lower leg, the forearm contains 4 compartments. These include the superficial volar, deep volar, dorsal, and mobile wad compartments.
The volar compartments are the highest risk and are usually caused by supracondylar fractures of the humerus in children and radial head fractures in adults.
The upper arm consists of 2 relatively large compartments called the anterior and posterior compartments. Due to their size, increased pressure is almost never seen.
Keep in mind that the hand and foot also have compartments. However, getting compartment syndrome in these areas is extremely rare.
But it does happen.
This is also true in abdominal and gluteal compartment syndrome.
Compartment syndrome is a clinical diagnosis and no labs or imaging are needed.
But what other workup could we get to nail our diagnosis?
A good place to start is an X-ray looking for a fracture, as this is the most common cause.
Also check a creatinine kinase looking for muscle damage.
In the setting of muscle destruction and rhabdomyolysis, potassium and creatinine may be high, and the urinalysis could contain large blood with small RBCs, which is classic for rhabdo.
These are good ways of telling if there is muscle damage going on, but is there any way to directly tell the pressures of the compartments and if they are elevated?
The Stryker needle can be used to measure exactly the pressure in each compartment.
Essentially, the Stryker needle is a handheld manometer. It is a device that has a 3 milliliter syringe filled with saline attached to an 18-gauge needle.
The skin overlaying the compartment is cleaned and the needle is inserted into the compartment. Around 0.5 cc's is flushed into the compartment and the manometer reads the pressure.
Some literature reports attaching an 18-gauge needle to an A-line setup gives just as accurate of a reading.
Normal pressures are typically less than 10 millimeters of mercury. However, most compartments can withstand pressures up to 20 millimeters of mercury.
Delta pressure is now used to predict elevated pressures rather than an absolute pressure. A delta pressure is a diastolic blood pressure minus the compartment pressure.
A delta pressure of less than 30 millimeters of mercury is highly suggestive of compartment syndrome.
As soon as the diagnosis of compartment syndrome is made, a fasciotomy needs to be performed. This is because permanent damage can occur if there is a delay in management of greater than 8 hours.
The days of bedside fasciotomies are nearly extinct, however they are still sometimes performed. Call orthopedics as soon as possible for operative intervention. Do not elevate the extremity and avoid ice as they can worsen microcirculation.
Resuscitate if necessary, as these patients can become hypotensive, go into renal failure, and have life-threatening arrhythmias.
To summarize, compartments are everywhere, including every extremity, the abdomen, and the gluteal region. Have a high index of suspicion for compartment syndrome.
Research has shown that the 5 Ps we learned in medical school for compartment syndrome might not have the best utility in diagnosing it. So scratch that.
Although compartment syndrome is a clinical diagnosis, a Stryker needle can provide some objective data to help out. Remember to use the delta pressure instead of the absolute pressure.
Fasciotomies are the treatment of choice. Where available, get your orthopedic doctor on board as soon as possible for the OR. So that's it for this case.
Send us your comments, suggestions, and cases to theclinicalcorrelation@gmail.com and follow me on Twitter @MDNotified.
And me @EMLLou.
Thanks for listening.